Hi everyone. Very happy that you could make it today, or with a little delay if you're actually watching this from home after your hard labor during the day. So hopefully that will be a very informative and very interesting webinar that we'll have today, which is a dear topic to a lot of clinical scientists and clinicians that are taking care of DOC patients, which is advocating for care for them and rehabilitation while they really, really needed not only with insurances, but also just explaining to other doctors why this type of intervention is working and is needed for this population. So I will just very quickly introduce you, Dr. Hu. So Dr. Hu completed the PM&R residency and brain injury medicine fellowship at Baylor College of Medicine. After training, she joined Baylor as an assistant professor in Ben Taub Department of PM&R and has been an attending physician for brain injury and stroke program at Tear Memorial Hermann, where she sees patients with disorder of consciousness. Her clinical and research interests are outcomes of disorder of consciousness from various etiologies, long-term care, caregivers' need, advocacy, and ethics in brain injury. Enjoy. Dr. Wu.
Thank you so much for the introduction. Thank you so much for this opportunity to talk about how to improve the access to inpatient rehab for individuals with disorders of consciousness. This is something that I'm very passionate about to discuss. And I know we have audience from potentially all over the world, but some of the barriers that I'll be talking about may actually be unique to the United States healthcare system. But I still want this talk to be the start of discussion among DOC clinicians and researchers about the similar barriers and how they have been addressed or have been overcome to learn from each other as well. So the objectives are to recognize limited access to inpatient rehabilitation for individuals with disorders of consciousness, and to identify barriers to access DOC programs, to list fundamental causes for these barriers, and lastly, to discuss how to overcome those barriers. Before we move on, in the United States, not all facilities that have DOC programs are licensed as inpatient rehabilitation, but some may be licensed as different entities, such as long-term acute care hospitals. So they may be actually under different regulations, they may have different criteria. So they may actually have some different type of finance, especially the financial barriers, than the one that I'll be talking about. So the current situation is that we don't have a centralized mechanism to track those DOC patients. So it is even difficult to measure what percentage of patients make it to the DOC programs and what percentage of patients are actually lost without us being even be aware of them. There was an international survey among DOC clinicians, and then the data showed that in the United States, the responders reported less than 25% of all people with DOC get access to interdisciplinary inpatient rehabilitation, which is a very low proportion. And in addition to that, the financial issues was found to be the major limitation to access the rehabilitation services. So why is this an issue? So although those patients are saved from acquired brain injury from heroic measures in acute care hospitals, for a variety of reasons, they are actually discharged to non-rehab setting under custodial care, such as homes, nursing homes, and skilled nursing facilities, where they're not equipped to have accurate assessment. They're not equipped to accurately assess the patients or treat the patients. So without those type of assessment, those people are vulnerable to misdiagnosis, which can lead to mismanagement, deprived of new diagnostic, therapeutic, and rehabilitative interventions that can help their neurologic and functional recovery. An increasing number of brain injury patients have and will survive from their brain injuries with newly developing acute care interventions, but their access to inpatient rehab which can promote further recovery and even community reintegration, doesn't seem to have caught up on that. So in order for someone who had acquired brain injury to get to DOC program, there are several hurdles that they have to jump over. First, they have to survive from their injuries, and then they have to be medically stabilized. Then the referrals to DOC program need to be made, and those cases need to be reviewed and clinically accepted by DOC programs. And finally, we have to have insurance approval to bring the patients over to the DOC programs. And each steps in this diagram can potentially be a barrier for these patients to access DOC program. So here's a list of barriers that we're going to talk about. First, we'll talk about survival. So these patients not only have to survive from their brain injury, but they have to survive through the end-of-life discussion, which sometimes happens very early in the right after the brain injury. One Canadian study that actually showed the high mortality rate in the first few days in the neurocritical ICU was associated with withdrawal of life-sustaining therapy, bringing the concern about this irreversible decision being made prematurely. Since the Quinlan case in the United States in 1976, where the Supreme Court ruled foregoing life-sustaining therapy for a patient who was in a persistent vegetative state, this right to die movement started in jurisprudence and medicine. Unfortunately, this presumption of utility was generalized to other conscious states that we have found since then, such as minimally conscious state and cognitive motor dissociation, although they have different prognosis. And then when poor quality of life, poor outcome, no meaningful recovery are presumed, people are likely to withdraw the life-sustaining therapy. The next barrier is lack of referral, which I think is a huge issue because even without referrals, we're not even sure how many people we're actually missing. So why are the referrals to DOC programs not being made? First thing could be mindset. For people who have severe brain injury, the rehabilitation can be deemed futile for the clinicians or the staff in the acute care hospitals. But it's also possible that there's lack of knowledge. Those clinicians, the physicians, social workers, case managers in the acute care hospitals may not be aware of the cases, the DOC cases with good outcomes, which can actually feed into the futility mindset. It's also possible that they are not aware of such thing as DOC programs or that this patient actually can go to inpatient rehabilitation program. And of course, if there's no rehabilitation programs nearby, their hands might be tied. But if known to the patient's families, they might be willing to want to take their loved ones to the programs even out of town, out of state, for best care possible. So if the disposition discussion is happening with this rehab option excluded, whether intentionally, unintentionally, I don't know if we can call this disposition an informed decision, which can raise ethical concern as well. So the next is clinical acceptance by DOC programs. There seems to be variability in admission criteria among the DOC programs in the country. One can be functional level. Some programs may accept the patients who at least inconsistently following commands. Some programs may be open to taking the patients who may look vegetative or very low level. Some programs may look at their chronicity, etiology. It looks like in general, people who have DOC from non-traumatic etiologies tend to have harder time getting accepted by the DOC programs here. And the medical complexity can play a role. Some facilities may be equipped to take care of vent patient, and then some facilities may not, for example. And the payer source can also be a factor. They play a role whether or not the DOC programs take the patients. And we'll talk about this more later in the presentation. And I also wanted to share some tier experience regarding this matter. And we as a field very reasonably thought that anoxic brain injury patients had poorer outcomes compared to traumatic etiology, as suggested by a lot of literature too. And in tier program, we also had the same thought initially. But we had a chance to accept few anoxic brain injury patients who actually surprised us by showing much better than expected outcomes. And we had also accepted patients who appeared to be in vegetative state, or someone even like were labeled as comatose state on record. But these patients, we actually commonly found out they had been misdiagnosed before coming to TIR. So this experience has actually reinforced the idea of how this patient can still be a good candidate for inpatient rehab. So we actually started taking patients with DOC from non-traumatic etiologies and people who appear to be very low level on the record. We actually had a DOC program meeting yesterday and reviewed some of the data. And then one of them was, one of the things that we looked at was how we had even more non-traumatic etiology than traumatic etiology in the last fiscal year. And then surprisingly, the outcomes of anoxic brain injury patients were actually comparable to traumatic brain injury patients, especially in terms of emergence rate. So just wanted to share that. And lastly, insurance denial, of course, can be a huge barrier to getting to DOC programs. So why are we getting all these denials from the insurance? And I believe a lot of the physiatrists in the United States will definitely mention something like Medicare guidelines or CMS guidelines for inpatient rehabilitation, which state patients are expected to actively participate in 3 hours of therapy a day and 5 days a week. And they also expected to make measurable improvement within a reasonable period of time. So this guidelines had been interpreted as DOC patients do not qualify for inpatient rehab because they are not able to actively participate in therapy. And then another thing is improvement standard, where the benefits are denied to patients who are not expected to make improvement or have failed to show progress despite receiving those treatments. But this application of improvement standard can be detrimental for our DOC patient population. Because of the limitations of conventional measures that we use to track our any rehab patient's functional improvement. So on the left side, it shows a GG score. It's a scale. It's like a ladder. You're climbing up the ladder to show them the improved function. And then the things that we look at is activities of daily living, which include feeding, hygiene, toileting, dressing and bathing, as well as mobility, which we look at band mobility, transfers, and even walking. So even if our DOC patients make functional improvement in terms of communication, decannulation, starting on an oral diet, their improvement are not captured by these conventional measures that we use, such as FIM scores or GG scores. So on the paper, it may look like our DOC patients are not improving at all, which is a problem too. So this is a tiered data from 2018. We actually looked at all the referrals and reviewed why those referrals, all the patients did not make it to DOC program. And we found that out of 100 referrals, more than half did not make it to the DOC program at TIR, and financial denial was the biggest barrier. One is because they had federal payers called Medicare and Medicaid, and sometimes the DOC Disorders of Consciousness program was not a covered benefit by policy. There's actually some insurance companies, they actually have a carve out for DOC. So at some point in our program, we thought about maybe not labeling them as a DOC, because you can actually harm the patient, their risk the chance of coming to the DOC program. But we also found out that some patients do benefit from being labeled as DOC, because if they do not have an inpatient rehabilitation program or any DOC programs nearby, the insurance will actually cover their transportation and then out-of-state DOC program, because it's not available. The specialized DOC program is not available near the patient. Another reason why there was financial denial was because TIR was not out of network from the insurance. So how can you advocate for admission to DOC programs, especially inpatient rehabilitation setting? So in order to target these first two barriers, I think we need to educate the clinicians and staff in the acute care hospital. So how do we do that? So I think we need to reach out to the feeder facilities like acute care hospitals, long-term acute care hospitals. And if you're in a smaller town or smaller city where there's a countable number of skilled nursing facilities and nursing homes, you can also reach out to them to educate. So we like to educate the staff, but not only physicians or therapists, but we definitely want to include the social workers and case managers who are the driving force when it comes to disposition discussion. We want to let them know about the source of consciousness and the DOC program through the presentation. So you can talk about types of patients that the program is looking for and accept, and interventions that are provided to this patient population. And you probably want to talk about the DOC outcome data, as well as the disability paradox, where how able-bodied individuals tend to way underestimate the quality of life of individuals with disabilities. So these two may actually challenge the presumption of utility, poor outcome, and quality of life that are commonly seen in acute care hospital. And then I also recommend giving this presentation regularly, given the staff turnover. And then with time, they'll also forget about this presentation. So as a reminder, just repeat the education every once in a while. And another way to increase referrals to DOC program would be increasing presence of PM&R consult in acute care hospitals and LTACs, or long-term acute care hospitals. Those consultants can assist with disposition for our patients, and they can also educate and empower the patient's families about this option of rehab, not to force them to come to the rehab program, but at least to make an informed decision, even if they do not come to the DOC programs. And another thing that I'll highly recommend is actually closing the loop. If you between the acute care hospitals and then rehab hospitals. Because if you think about it, we as a rehab, on the rehab side of it, we don't get to see how bad our patients looked initially when they first presented to the hospital. But on the other hand, the acute care staff, they don't get to see how well their patients can do because there's usually no follow-up in the ICU. And then the only time they will see their patients back is when they're not doing great. So at TIER, we created a project called Thank You for the Referral. The idea is to videotape our patients expressing this phrase, whether verbal or nonverbal, and then with permission, we send it to their physicians or case managers, social workers at acute care hospitals to show them better than presumed outcomes of DOC patients. And if you do have these videos, you can also include it in your educational presentation so they can see their own patients, how well they're doing. So I included some of the several samples that we have to show you how we made this video. I'm going to stop sharing here. And then we'll show you this video. Give me a second. This video has a small volume. So what he was saying was, thank you for the referral. And then he finished it with a smile. And let me go back. And this is him after discharge with his wife. And this is another case. This patient actually sent me this photo when he found that I'm giving this talk because he wanted us to see the contrast. So how he looked in the acute care hospital and how he is right now. So let me show you this video as well.
Thanks so much for confirming here.
So this was when he was still in our hospital. And this is him after discharge at home. They built parallel bars in their garage. And this is him at his sister's wedding. And this video, so not every DOC patient at TIER end up talking verbally, but this patient was actually able to communicate by typing on his tablet. So we asked him if he can type it, and even before we finished saying it, he started typing. So the video starts with A, not TH. I'll also show you this video. So there are some typos, and he may do like a backspace to correct. So
A N K N Y O U R W F
backspace.
E F F E R I N G T O 2 M E me T I E R.
Good job. What does that say?
Are you referring to me, Tyre?
He actually spelled TIRRTIER. And this is another video. Also, he does not talk, and he was not able to type. So what we asked him is, what we did, we scrabbled the words, and we had him organize them in order by himself. So again, he was also admitted as DOC patient, labeled as vegetative. So it was kind of slow, so I fast forwarded a little bit. So you can hear the noise. There's no one guiding him what to say, how to do it. So on his own, he's putting the words in order. I kind of fast forwarded a little bit. So he found out there's something didn't make sense. So he corrected it. And now he's satisfied. Okay. And this is him at home with his family after discharge. And then this is the last video that I'm going to show you.
Thank you for referring me to here.
And then a couple months after discharge, he is at home back in college. And then lastly, in order to improve the access to DOC programs, we definitely need to increase insurance approval for inpatient rehabilitation or DOC programs in general. So I listed 3 categories how we can do this. One is clinical work, one is through research, and one is through advocacy and policy change. So from clinical standpoint, we highly recommend collaborating with the referring teams in the acute care. So when the DOC referral is denied, a lot of times peer-to-peer discussion is offered, where the physician from the referring physician get to have a discussion with the physician from the insurance company to discuss why it was denied and why the patient actually needs it. It can be done by PMR consultant if available, but if not, the referring team would have to talk to the insurance to advocate for inpatient rehab or DOC programs. But a lot of the times, because of their limited experience and they're not fully aware of what are done at DOC programs, how we do it here is we actually offer to help them. So the nurse liaison or consultant will connect us, the DOC teams, to the referring teams. So we actually share the talking points so that they know what to say when they're doing the peer-to-peer. And sometimes, depending on the situation, we also provide a letter of support for the insurance. And then when we are talking to the payers, I would definitely mention the American Academy of Neurology DOC practice guidelines, which makes the DOC program actually a standard of care, not an experimental intervention, which we have heard before from insurance. And we have to talk to them about how inpatient rehabilitation is medically necessary and reasonable. And how we do it first is explaining to them that we actually provide better diagnostic accuracy and prognostication. I definitely mentioned about a high misdiagnosis rate, which is noted to be up to almost 40%. So it's possible that the insurance policy, they are denying the patients based on misdiagnosis, which can be troublesome. And also tell them about the limitations in assessment and resources in the acute care setting. Because of the goal of the acute care team is to keep the patients medically safe and survive, not really look for the signs of consciousness. And there could be a lot of confounding factors. The patients may be on multiple sedatives. They might be just recovering from surgical intervention. They might be actively being treated for infection, so which obscure the accurate assessment of their level of consciousness. And also the frequency of assessment for signs of consciousness may be also limited because their goal is different than finding the signs of consciousness while they're trying to be safe, kept alive. And also the clinician's experience. In the acute care hospital, their experience could also be limited because of the needs in the acute care setting. That's different than rehab. And also talk to them about the rehabilitative intervention that are going to be provided in rehab setting, which is not available at other disposition options. So first of all, we talk about mobilization, verticalization, which might be even sufficient to improve our patients' arousal. Pharmacologic interventions that we do to improve their cognitive function, aggressive spasticity management, use of modalities, and then attempt to initiate communication, either verbal or nonverbal, the use of augmentative alternative communication to expand their communication, tracheostomy advancement, starting PO trials, and which can signify improved secretion management too for the patient. And also wheelchair bed positioning program, so they are not developing contractures or anything from poor positioning. And also talk to them about functional improvement, things that are commonly achieved for our patient population, such as emergence from minimally conscious state, communication, decannulation, swallowing, and sometimes people do make theme score changes in ADLs and mobility too. So definitely talk to them about the improvement that are expected from some of our patients. And I'll definitely highlight the decreased secondary complications readmission to the hospital, which are going to cost insurance more money if that's the case. So by doing active mobilization, spasticity management, we prevent a lot of skin breakdown, which can have high risk if they are not appropriately managed in different settings. Also, we try to prevent contractures because once developed, the only way to reverse will be surgical interventions, which can be costly too. And by improving their swallowing function, protecting airway protection, we can potentially also decrease the risk of aspiration pneumonia, which will decrease the rate of readmission to the hospital, ER visits. And also talk to them about the rate of home discharge instead of going to different facilities that they'll have to pay for, like skilled nursing facilities or LTACs. Because our therapists do a good job doing the DME assessment and then doing the family training so that our patients can be safely transitioned to a home setting, which I think consider as community reintegration too, because they are not institutionalized. And in order to have a good talk with them, it's going to be helpful for you to know what your program can offer to individuals with DOC. For example, if it's spasticity management, do we offer serial casting? Do we do injections such as botulinum toxin, phenol injections? Do we do intrathecal baclofen trial for more aggressive diffuse spasticity management? And also, every once in a while, review the outcomes from the program to support the benefit of inpatient rehab. We can talk about the rate of achieving the goals, such as how many patients are actually get decannulated, how many of them establish communication, etc. And I think home discharge rate is another good thing to look at to support, to convince them how inpatient rehab or DOC programs can benefit this patient population. So I include this sample, the template of our letter of support. This is a tier version, but depending on what program can offer, the different programs can definitely make some changes, and then also feel free to share with the acute care teams if needed. So this letter basically just specifies what we talked about so far, the benefit of inpatient rehab, and then the goals that we have for our patients. So the next thing that we can do to increase insurance approval, I think, is through research. Because we need more data, we need more evidence to support that, to prove that DOC rehab is reasonable and necessary for our patient population. So publishing outcome data to support the benefit of DOC rehab will be critical. And I'll highly suggest that we also start including non-traumatic etiologies, given the more challenges they face to get into DOC rehab too, while they can still have comparable outcomes to traumatic etiologies. I just want to share one example that was published, tier data by Dr. Zhang in April this year. So in this paper, we talked about the rate of emergence, decannulation, oral diet initiation, even FIM score changes that our DOC patients made. And the more outcome data that we have, the better evidence, the more support we will have. And another thing we can do is creating a scales or measures that can actually capture our patients' improvement, other than GG score or FIM score, to show that they're actually making improvement, measurable improvement. Also publishing more guidelines and reinforcing them, just like the A and DOC guidelines, to make the DOC rehab as standard of care. And then for future studies, it'll also be interesting to know the comparison of the outcomes or the cost effectiveness between the group of patients of who underwent DOC rehab, and then the group of patients who actually never got to do a rehab. And then I think national, even international registry of DOC rehabilitation may enhance the data set and also enhance our evidence. And I know there was a series of common data elements for DOC published by Curing Coma Campaign Group to collect the data in a consistent manner and standardization. And I think this is a great initiative. And then lastly, that what I want to talk about is advocacy and lobbying. This field, I was not, and I'm still not familiar with this field. But then the more peer-to-peer that I do every day, not every day, like multiple times a week, the more I realize that the change has to come from above. I mean, doing peer-to-peers fighting the insurance is also part of advocacy, but by reaching out top, I think we'll be able to make impact for a larger population more effectively. So I had to include this in our presentation. So patients who care, I think a lot of our physiatrists in the United States would definitely mention CMS, something to be changed with the CMS guidelines. Because patients who carry the federal payers, such as Medicare and Medicaid, have very limited access to DOC programs. And it's not because Medicare and Medicaid deny inpatient rehabilitation, but then the limited access is due to interpretation of the CMS guidelines for inpatient rehab, the 3-hour rule and how they have to make the measurable improvement, because it creates a risk of rehab not being reimbursed by Medicare and Medicaid. And it is actually Medicare Administrative Contractors, or MACs, that audit the cases and determine whether or not they want to reimburse the inpatient rehabilitation for DOC patients. So at TIER, we reached out to the original MAC and discussed the DOC rehab, whether this type of inpatient rehab will be reimbursed. And the answer was no. So based on this response, TIER has not been taking the Medicare Medicaid patients, which is why, depending on the payer, the DOC admission can be limited even without actual denial. But there can be variability in terms of how each MAC, the regional MACs, interpret the guidelines. So it may not hurt to reach out to them and see what they say, if they're willing to pay for it or not. So in order to tackle that, the CMS guidelines, we can maybe reach straight out to CMS for explicit specification that DOC patients actually qualify for inpatient rehab in some ways. I think this will open up, if possible, the door to inpatient rehab significantly. And not only the patients who have federal payers, but also the ones who have commercial insurance or private payers, because often they denied inpatient rehab for DOC patients based off of their interpretation of CMS guidelines. So reaching out to CMS and then talking about the issues might be also the first step. Another thing is we need to increase awareness of these issues among policymakers and even potentially legislators. We thought about maybe doing a concerted effort among organizations from different disciplines, not just PM&R or physicians, but also trauma surgery, PT, OT, and speech. Maybe we can all collaborate to relay the same message through submission of formal testimony or written comments. In one of his articles, Finn's actually, I quoted him here, as the comprehensive treatment surrounding DOC evolve, so too must the policies that affect the patients. So we need to take some actions to make it more appropriate for our DOC patients as our medicine, our science evolve. I wanted to include this case, Jimo versus Sibelius. Jimo, who had a chronic medical condition, she was actually denied of skilled services by Medicare on the grounds of she will not get better. So they actually challenged the use of improvement standard, and actually the judge approved a settlement where the coverage decision should be based on individual condition, and unique clinical needs instead of generic assessment of assessments such as improvement standard. So based on that, CMS actually changed their manual and policy and guidelines so that to ensure the coverage for skilled maintenance services in home health, nursing home, and outpatient settings. But although it does not include inpatient rehab settings, I wanted to mention this case because this is a case where the CMS actually changed their manual and policy to a litigation. So is litigation one way of changing the policy, potentially? So what else? So I think we need to educate our future clinicians. We need to expose trainees like residents and the students, not medical students, but even PA students, pharmacy, therapy students to DOC. So even if they do not become DOC clinicians, they can also disseminate their knowledge on DOC in their own field, which will result in increased awareness of DOC in healthcare in general. Just to share a couple examples, I had former residents who are in sports, who are in consult, doing different things, non-DOC practice, but they always reach out to us about patients they see who seem appropriate for DOC programs. And then they also improve the referrals and they get what the care that they need. I also have PA student on my service, and then there was a student about a couple of years ago who's now in a totally different field, but she saw once a patient who looked appropriate for DOC program, and she reached out to me about how to get the patient into DOC program at TIER. So this was a very good example of me realizing how even teaching and exposing the trainees who are not even going to brain injury or DOC can actually improve our patients' access to DOC programs. And I think we should also increase awareness of DOC in community, not just in the healthcare, so that the people who, if they need it, they know they can ask for, hey, can my loved ones can go to DOC programs or rehab. So these can be done potentially through social media, which is commonly used these days. You can post stories with permission, or even the patients themselves or families can also post their stories on social media if they want to share it. We can also think about maybe starting a viral challenge videos. I don't know if you remember the Ice Bucket Challenge for ALS in 2014. And then based on the media, I also learned that they raised a huge awareness and also funding for research. that led to better care and then treatment, I guess. And then you can also use news stories, columns, reports to make them be more aware of the DOC stories. And also you can utilize community outreach. Maybe you can do like educational event locally to improve the awareness and DOC community. So despite all the efforts, the system is not going to change overnight, realistically. So in the meantime, what I think will be important is keeping all the DOC patients in the loop. So maybe we can develop a system where once a patient is referred, even if they do not make it to DOC programs, there's a way we can keep an eye on them so that either through having a DOC navigators or having nurse liaison keeping an eye on them, or once they're referred, even if they don't come to DOC programs, schedule them to see you in outpatient clinics so that you can continue to keep an eye on those patients. So this will provide us with opportunity to reassess for emerging signs of consciousness over time. So when it's appropriate, we can refer them back to inpatient rehab without having too much delay. So this is my summary to go over some common barriers that we discussed, the fundamental reasons for those barriers, and how to overcome those barriers. So we first talked about the withdrawal of life-sustaining therapy in the acute care. Likely is happening because presumed poor prognosis, outcome, poor quality of life. So how to overcome that? We probably want to educate the staff on DOC outcome, even disability paradox, how those people can still value their lives, quality of life way higher than what we think. The next one was lack of referrals to DOC program. And again, presumed futility of rehabilitation, lack of awareness of what DOC program is, what this patient can still benefit from inpatient rehab can limit the number of referrals to DOC program. There's also a huge gap between acute care and rehabilitation. So what we want to do about that is reaching out to them, educate the staff through presentation, advertise the DOC program, let them know about this option, and try to close the loop in any way. I just shared the example of thank you for the referral project at TIER. And then lastly, we talked about insurance denial, which we struggle a lot almost daily. The reason could be because of the CMS guidelines, Medicare guidelines, at least in the United States, because of the interpretation of the guidelines saying the patients are not able to actively participate in rehab. They're not going to make measurable improvement. And there's also lack of measurement to capture their actual improvement. So how we want to tackle that? We want to collaborate with referring teams, and publish more outcome data, create tools to capture our DOC patients' improvement, and also try to advocate for better access to inpatient rehab or DOC programs through advocacy and lobbying. So that is the end of my presentation, and I'll be happy to answer any questions the audience may have.
This was awesome. Thank you. I really loved it. There are so many different ways we could tackle this. I mean, it's obviously a gigantic task. I think that there was one question related to the fact that there are some patients that indeed have a very certain profile where they, you know, are maybe non-traumatic, as you said, are more chronic, and then they do not get to these and have certain complexity indeed, and then do not get to this rehabilitation that they really, really need. And I think this question really covers the continuum of care that is unfortunately lacking here. I wanted to ask you, so the tier is not recognized as an LTAC, right?
Right, we are an inpatient rehab hospital. So there's a lot more regulation through the guidelines.
To accept ventilated patients.
Right. So we pretty much accept anyone. My mentor used to make a joke with it. If the patient has a pulse, we'll take them.
Yeah. Where there is a pulse, there is hope. But yes, I think that there is definitely a link that has to be made between the acute and the chronic to allow that continuum of care. I really like the Cure in Coma campaign, for example, for that reason, because really having this link with the acute care is very important. Now, I think that just having some media attention, journalists and things like that, is very important. I was thinking recently, I have seen a few patients recently that had struggles that are definitely not in a rehab unit or anywhere it's SNF or nursing home, where they have patient's right issue, I would say. And I think that this is something that could, maybe interest the media. Maybe we should, go out there, the IBIA doxig I'm referring to here, and just have something that is coordinated, but there and move along in the future. I would love to invite you on our family task force, because there are definitely an effort made there from the IBIA to develop things for families. And even though we're a bit overwhelmed with our work and so on, we try to make it more and more accessible to families, and just have a multiple direction, right? Where you have not only contact with other professionals who do not know, but also with families, because families are resources. They have so much resources. And in my experience, when I actually include them in that effort, I get way more because they have skills. For example, I have one patient, his son will be working for Google or Facebook, and so they will help in their own way because they're motivated, of course. Right. So even if they do a little bit, I think that, involving families and trying to not only seeing them as consumers, but also as a part of advocating for the care of these patients is really key. But I don't know if you would see like the next step for you. What would it be concretely? I know it's a big question. It's a loaded question, but.
Right. So I will start with having this type of talk so that rehab field as a team, as a whole, can also relay the same message and then work towards improving the awareness in the, especially in the healthcare field. It's actually surprising how even the healthcare professionals in non-rehab field are not aware of this option. So I think that's going to be the first step. And then the policymakers, legislators, that might be another, again, I'm not too familiar with it. I'm in the process of learning about this right now. And also, just like you mentioned, I also encourage, there are actually Facebook groups among the families whose loved ones were former TIR patients. So they're also educating each other. And then we also learn from them a lot. So also utilizing that group to improve awareness in the community, I think that also going to be a good option that we can utilize.
Yeah, education for a lot of different people, but also trying to join forces with a lot of different actors.
Right.
Marilyn, I think that you had a question. Please go ahead. Unmute yourself, Marilyn.
I want to thank you, Dr. Wu. I think you did a great job in covering all the barriers and issues. But I do have a very major question. In your presentation and from the questions and comments made by the folks that are on this call, I never heard the mention of the Brain Injury Association of America or the Texas advocacy that's been going on for a number of years. TIR has been part of our Brain Injury Association family for many, many decades. And when you talk about advocacy and lobbying, the Brain Injury Association in every state practically has been doing a job of advocacy and lobbying. This is not a new issue for any of us. And many of the things that you have suggested have been done. Uh, I've been at Spalding for 21 years, retired. And prior to that, I'm the founder of the Brain Injury Association of America and most of the states.
Wow.
And one time, a man by the name of Charles Haynes, who was very involved in the formation of the International Brain Injury Association, Charles Haynes, I'm sure you know his name. It was his sister that caused their father to become very active with me way back in the 80s. And you've done a very good job. That seems to be forgotten. So, and I want to bring it back to you because you don't need to start at square one. You are already involved with, you're already involved with the Texas Brain Injury Association doing some of the things that you've mentioned, and I'm not sure that you may be aware of that. The question that you raise, I'm going to go back to the Centers for Medicaid system, the CMS.
Mm-hmm.
Terrible. They have done a violent job for our patients. My daughter was in a minimally conscious state for over 5 months. And I was told that if I was a smart woman, she should die. I should let her die. Well, I'm 40 years later, and I tell you, Deborah Price is no vegetable. And I would expect, since TIER, Spalding, Craig Hospital, and NYU, Mount Sinai, all of the systems, the rehab hospitals that have been doing this and doing it well for so many years, if we put together, and it has been done, it's been done and they're out there, put together a fresh video of the people that were in this state where time was the best remedy with guidance from the world of rehab.
Mm-hmm.
We weren't with a 3-hour minimum that would not allow people today to even access TIER or Spalding. And there are very few long-term care hospitals left in this country. And if they are in existence, they don't have the expertise of staff like you have, or staff, or a Joe Gisino on staff. So putting them in a long-term care hospital without the guidance and the expertise of the staff that's going to serve them is no help. No help. You talk about contractions. That's one of the issues that I dealt with back in 1980.
I see.
We are putting people to death. We're throwing away these people. And if you took a video,
Marilyn, I think that definitely there is I think that the message that you give to join forces is very true. So that would be great if the IBIA, the Brain Injury Association of America, could join forces for that, and just have also, different partners to do this, because everyone is doing his own thing in his corner, because simply sometimes it's just a question of time.
well,
People are just, racing and not seeing what there is around, and thinking they are the only one to do it, while actually there are other efforts made. And internet is wonderful, but sometimes it feels overwhelming, and finding the right information, except if you spend some time to search for it, might be very difficult. And so that should be changed too, the way we disseminate information. But it's hard to find ways to reach families and to reach the actors that could help join forces, and sometimes even to convince people to join forces, because they are, very proud of their effort, and they would like to stay on their own pride of having developed their own thing. So it's difficult sometimes to let that aside and just join forces and share whatever you did. But that's really something that would be great. And the ACMRF, of course. For example, there is the education for the families that now has been done, and they are trying to find a way to have it to find a place on the web where these resources can be available to anyone. I think they tried the brain link or something like that, and it's very hard because you have to find money and make sure that this is they're posted, but then that there is someone updating the link and making sure people have access to it. So definitely something that that needs to have a more common effort. That's the reason why I like the current coma campaign, because it really like to coordinate this effort and make the link between the acute and chronic. But definitely happy to talk with the Brain Injury Association of America if that would be possible to join efforts. And the ACRM, I mean, it's already there is already a link there, but it needs to be developed.
Yeah, I just started shifting my eyes from just daily clinical things to advocacy. So I'm also learning a lot, and I would love to hear more about the options, opportunities to get involved.
Yeah, I think there is a lot out there. I can talk about the IBIA because I can unfortunately not talk about the Brain Injury Association of America, but that would be great to be in contact. So maybe Marilyn, you could put me in contact with some of these people, just to make sure that I'm making the link in between and have maybe some efforts to join forces. Jean, I will definitely send you an email to join the family task force, because I would love to have a brainstorming and just discuss about the different things that should be done and maybe prioritize. I'm just looking at the chat to make sure that there is no other question, but that was absolutely yeah. Thank you for your presentation, Dr. Wu. Thank you for this, Dr. Wu. So there is a lot of thank you for your effort to talk about this. It seems a little bit silly to talk about those things because we all know about it, but it's really important to just point out that not only it's there, but you can do something about it. It's just a question of identifying what needs to be done and then prioritizing, and the teamwork, because you cannot do anything without a team with you. So I think that's pretty much, I'm trying to see. Yeah, there are a lot of people that thank you very much for your effort.
Thank you.
Okay, well, if there is no other question, then I will just end this webinar. Thank you very much again, Dr. Wu. It was really fantastic. If anyone has any question related to this webinar, they can send an email to me. My email is on the DocSig website, and or contact Ginger Vasquez and ask your question. She will most likely forward it to me. Just for you to know, guys, we'll have another webinar in December, and we'll talk about multimodal assessment and PET scan more exactly. There exists now a pipeline that clinicians might be able to use for their PET scan that they just did, just downloading their data and having a report generated automatically for a patient with DOC. So pretty exciting. We'll have the developer talking about that in November. So don't miss that webinar. And there will be every 2 months something coming. So just wait for it. Okay. Meanwhile, again, thank you very much, Dr. Wu.
Thank you for this opportunity.